Hello, and welcome to year 2 of the My Mind Zero Suicide Initiative. As you may know, my name is Leslie Johnson, and my pronouns are she, her, and hers. I'm excited to see you back here for our second year of training. Year 2 will focus on diving deeper into the concepts we introduced in year 1 and beginning to think more strategically about your care pathways. Before we get started, I need to make you aware of this. Support for My Mind is provided by Blue Cross Blue Shield as part of the BCBSM Value Partnerships Program. Although Blue Cross and My Mind work collaboratively, the opinions, beliefs, and viewpoints expressed in this training do not necessarily reflect the opinions, beliefs, and viewpoints of Blue Cross or any of its employees. Here's our agenda for today's training. We'll begin by doing a deep dive into lethal means counseling, and we'll have some case studies that illustrate different situations that you may encounter when counseling on lethal means. Then I'll introduce you to another quality improvement tool, the Fishbone Diagram, using caring cards as an example. I'll take you through family clinics' use of a fishbone diagram to discern why caring cards were not sent by their providers and the PDSA that they create about it. There's a lot of material to go over today, so I'm going to dive right in. In your first year, we discussed the care pathway and talked about the importance of screening and assessment. This year is all about applying quality improvement to Henry Ford's zero suicide interventions to strengthen care pathways and support at-risk groups. While your first year provided you with a starting point for your zero suicide work, we want to ensure that the zero suicide process is fitting well into your clinics. In order to do this, we'll spend the next year examining some of the core competencies of Henry Ford's zero suicide and at-risk populations and help you think about how best to apply these concepts in your daily work. Today's training is going to be part of that. To highlight just how critical your work is, I want to share a powerful statistic from the CDC. In 2023, 27,300 people died by firearm-related suicide. Within the zero suicide framework, we believe these deaths and suicide attempts are preventable. That's why lethal means assessment and counseling are essential parts of the zero suicide care pathway. This slide shows just how common firearms are in suicide deaths. And it's important to remember that firearms are the most lethal means for suicide. In fact, 9 out of 10 people who attempt suicide with a firearm do not survive. But there's hope. Talking about lethal means can make a real difference. One study found that these conversations can reduce suicide risk by up to 75%. That's why lethal means assessment and safe storage should be part of care for every patient. Even if someone isn't at risk themselves, someone else in the household might be, and they could have access to the firearm. And firearm ownership is widespread. One study found that about 1 in 3 households in the United States has a gun. So these conversations definitely matter. Over the next few slides, I'm going to walk through specific case examples and tips to help you compassionately and quickly counsel on lethal means and determine if follow-up action should be taken. As a reminder, at My Mind, we recommend asking patients about access to firearms no matter their risk level and to take steps towards means removal anytime a patient is at elevated risk for suicide. As you'll see in the upcoming examples, firearms are not the only lethal means that you should be considering when speaking with patients at risk for suicide. In the first year, we reviewed lethal means counseling and the basics of discussing it with patients. As we begin a deeper dive into this subject, I'll start by talking about a situation in which the patient has access to lethal means and agrees to removal. It's important to normalize this discussion and emphasize that you ask everyone about lethal means. As I go through these different situations, remember that the process of lethal means counseling is the same, but the patient response is different. As a reminder, there is a one-page guide on the My Mind Partner portal called Weapon Safety Protocol that can be used to facilitate lethal means discussion at your clinics. Now I'm going to start by talking about a situation in which the patient has access to lethal means and agrees to removal. It's important to normalize this discussion and emphasize that you ask everyone about lethal means. One study mentioned that some providers are hesitant to discuss lethal means with their patients because they're afraid to break the relationship of trust that they have with them. But remember what you learned in year one. The more you practice lethal means counseling, the more comfortable you'll become when speaking with your patients. And if you bring up lethal means in a non-judgmental way, you'll have less risk of them losing their trust in you. Now we're going to have some practice. This is Charles, a 49-year-old African-American male. He has a history of type 2 diabetes and hypertension. Both are well controlled on medications. He's married and he uses a firearm for hunting, which he keeps stored in a gun safe when he's not using it. Today, during a routine follow-up on his diabetes and hypertension, he scored a 2 on question 9 of the PHQ-9. In this scenario, let's say that Charles lets the provider know that he is having passive suicidal ideations, and so he's at moderate risk for suicide. Think about how you would approach the lethal means discussion. In this case, he agrees to have his firearm removed from the home. So how would you go about coordinating this removal? And would you involve other clinic staff members in this discussion? Here are some important takeaways from the previous case example. A couple of reminders here. Remember to create and update a safety plan with the patient. Consider sending a caring card to him and document all actions and support person involvement in the patient's chart. I'll be highlighting these key takeaways after each case example, and the points that are unique to each situation will be in bold. Next, I'm going to discuss a case example that walks through a situation where a patient with suicidal ideation but no plan or intent declines to have a firearm removed from the home. I hope this example provides you with some tools that you can use if you find yourself in a similar situation with a patient. We know that some patients may feel that they need their firearm for safety or even for their job. Well, this can be overwhelming as a provider. I want to equip you with some tools and talking points to use with patients to modify risk as much as possible. In this case scenario, we have Marge, and she's a 34-year-old white woman with a history of anxiety and depression. She's married, and she and her husband have two middle school aged children. Her previous therapist recently left the practice, and she's seeing a new therapist for the first time. She scored a 1 on question 9 of the PHQ-9 and admits to feeling overwhelmed and having occasional passive suicidal thoughts without plan or intent. She and her husband both carry firearms for protection. In this scenario, she declines to allow anyone to take the firearm, saying that she feels safer with it in her neighborhood, where a neighbor was recently robbed and assaulted. Think about how you would respond to her refusal to let anyone take her firearm. What other safeguards can you put in place? Here are the takeaways from the last case study. You'll want to create a safety plan or update an existing plan with the patient and encourage the patient to keep a copy of the safety plan with them as a reminder that they have resources. And it's important to document the conversation, safety plan, and involvement of the support person in the patient's chart. Finally, this conversation needs to be revisited regularly on the patient's subsequent visits. Lastly, I'm going to go through a case study that reviews ways to manage a situation where complete removal of lethal means is not possible. As I said earlier, firearms are not the only lethal means that we need to consider. Things like stashes of medication are also a significant safety risk to patients who are at elevated risk for suicide. But sometimes it's not possible to completely eliminate access to medications that may be necessary for somebody's health. Here we have a 74-year-old male with multiple medical problems for which he takes many medications. He's widowed but has a daughter who lives near him and who is supportive. He was recently diagnosed with prostate cancer and he is currently undergoing treatment for it. He scored a 3 on question 9 of the PHQ-9 but denies plan or intent. He does say, though, that he's comforted by the thought that if his conditions worsen significantly, he could take all his medications and just go to sleep. Think about how you would handle a situation like Alfonso's and how you would get his daughter involved in the discussion. Here are the takeaways from the last case study. In this scenario, you will want to involve the support person in getting the medications off the premises as much as is possible. You'll also want to create a safety plan or update an existing plan with the patient and encourage the patient to keep a copy of the safety plan with them. And of course, just like in the previous case examples, it's important to document the conversation, safety plan, and involvement of the support person in the patient's chart. And just like in the previous case, this conversation also needs to be revisited regularly on the patient's subsequent visits. In the previous cases, the patients had support persons who could help them with lethal means removal. Unfortunately, you may encounter patients who either don't have a support person or who decline to involve a support person and who cannot or will not completely remove lethal means from their home. Examples of this situation include a police officer or security guards who are required to carry firearms and people who use firearms for personal protection. Some people are also avid hunters or collectors and they won't relinquish their firearms even temporarily. Others may have a sentimental attachment, like owners of firearms that have been in the family for generations. It's also impossible to remove all lethal means from the home. Think about what you would do in these situations and what safeguards you can put in place for these patients. In general, when discussing lethal means, we encourage you to speak with your leadership and policy or legal teams to ensure that you understand your system's policies surrounding lethal means removal for patients. Now that I've reviewed lethal means counseling, I'd like to remind you about an important resource for your patients, Lock to Live. Lock to Live is a website that takes your patient through deciding how and where to remove lethal means. It has a summary that your patient can print and keep for reference. There are also sections called See Their Stories, featuring stories of people who safeguarded their lethal means. And under the Talk to Someone tab at the top of the website, it has decision aids that are printable in both English and Spanish for those who can't fill them out on a computer. Since we've talked about why lethal means assessment is such a critical part of suicide prevention, let's shift gears and look at how you can apply this and other key elements of the care pathway to your day-to-day work. I'm going to introduce you to the Fishbone Diagram that can help you to brainstorm solutions to problems in your clinics. Then I'll review the PDSA and Model for Improvement and take another look at SMART goals. As you will see, these quality improvement tools can support the implementation of evidence-based practice like caring contacts, helping to strengthen your clinic's suicide prevention efforts. We'll be asking you to complete another PDSA cycle this year. The next PDSA cycle can cover any zero suicide process change, but focusing on strengthening your zero suicide care pathway will be strongly encouraged. We'll talk more about your care pathways at your next trainings. I'm going to start this section of the training by reviewing caring cards and introducing you to the Fishbone Diagram. This is also known as a cause and effect diagram or the Ishikawa diagram after its creator, Koru Ishikawa. Fishbone diagrams help teams brainstorm and organize potential barriers by grouping them into categories like people, processes, environment, or tools. This structure makes it easier to pinpoint what's contributing to a challenge and where to focus your improvement efforts. Using a fishbone diagram early on helps clarify the problem and sets the stage for a more targeted and effective PDSA cycle. You can also use a fishbone diagram to help determine what you will work on for a PDSA. You can easily draw a fishbone diagram or use a template that you can find online. To show you a fishbone diagram, I'll be using caring cards as an example. Remember, sending caring cards is a simple but effective suicide prevention tool. However, since caring cards are usually sent after a patient's appointment, this is one tool that can easily be overlooked if clinics don't have a standard process in place to ensure caring cards are sent to all patients at risk. You'll also see that small clinic problems can quickly become bottlenecks to sending out caring cards. That is why it is helpful to use a fishbone diagram to explore what causes may keep your clinic from sending out caring cards to patients. As a review, we're aware that sending caring cards after an appointment is an effective strategy for reducing suicide. A caring card shows a patient that the provider and their staff care about them and are thinking about them between appointments. An effective caring card should always outline what resources the patient can contact if they need help before their next appointment. In a caring card, the provider should list the clinic's phone number, and they should always give crisis resources like the 988 call and text line. My mind recommends that caring cards always be sent by behavioral health providers, but are not required by primary care. Caring cards can be a low-cost and effective strategy for suicide prevention. They can be sent by physical copy through snail mail or electronically through the EMR. It's important to review what bottlenecks are getting in the way of your clinic sending caring cards because we want to ensure this effective tool is not overlooked in the hustle and bustle of busy clinics. My mind suggests using caring cards in outpatient care at the time of the first missed appointment, at any time a patient is at high or acute risk, or at times of non-compliance with treatment. This tool can also be used for any patient that you feel would benefit from a follow-up. Remember, when in doubt, reach out. We also suggest providers in inpatient or residential use units send a caring letter on the day of discharge from care. If you want to get a head start on creating a caring card, templates for 5 caring cards are available in the document library on the MyMind Partner portal. Here is an example of a caring card. You'll see here that the provider has expressed that he's thinking about the patient and reminded the patient to reach out if they need an appointment. The provider then goes on to remind the patient of the most important phone numbers for the patient to call or text if they are in crisis. While you can create your own version of the caring card, please feel free to use this template and add your organization's information so you can send this out to your patients. And of course, you can always add a personal note to the card as well. Carrying cards are important tools for supporting your patients, but may be challenging to incorporate into your clinic processes, as we will see in the next slide. While carrying contacts are great interventions to modify the risk of suicide, there are also some natural barriers to sending carrying cards and follow-ups. One barrier is that carrying cards aren't sent to everyone, so they're not part of the normal clinic process. Staff members also have multiple responsibilities, which can sometimes make it hard to fit sending carrying cards into their day. And generally, clinics are busy with patients all day and can have unpredictable urgent visits, making adding a new process to existing clinic processes difficult. While these barriers exist, I want to ensure that they don't keep your clinic from sending carrying cards. This is where the fishbone diagram comes into play. You can use it to sort through all these barriers so that they can be systematically worked through. I'll show you an example of this now. In order to identify the barriers to sending carrying cards and letters, it helps to be able to list each barrier out so that you can see them all and develop a plan for addressing them. The fishbone diagram is made to explore what can be many causes influencing the problem you're trying to solve, which is referred to as the effect when creating a fishbone diagram. Many times, there is more than one cause for an effect, and this is a good way to sort through the various causes. The classic fishbone diagram has 5 categories of causes: materials, methods, equipment, environment, and people. When creating a fishbone diagram, you can use these categories, but you can also choose categories that better fit the problem that you're trying to solve. Now I'll take you through the construction of a fishbone diagram. First, you write the effect that you want to influence in a box on the right-hand side of the page, like this. Then you draw a horizontal line across the page to the left from the box that you drew. This becomes the spine of the fish, so to speak. Then you decide on 5 or 6 categories of causes for the effect. You can use the classic categories that I mentioned or create your own categories depending on what your causes are. Here, you draw the diagonal lines above and below the horizontal line. These are the fish bones. Then you would label each line at the end with one of your categories. For each category, you'll generate a list of the causes that contribute to your effect. You would draw lines out from the fish bones and write your causes on the lines. You would also group your causes according to the categories that you have chosen. So now I'm going to share the case of Family Clinic and its work to send caring cards to the patients in their care who are at risk for suicide. Doctors Victor and Kelly introduced the idea of caring cards to the other 6 providers at Family Clinic in June. Well, initially enthusiastic about the plan, the other providers only sent the cards out sporadically, if at all. So Doctors Victor and Kelly spoke with the other providers and created a fishbone diagram to help determine what barriers existed to sending out their caring cards. Here is the fishbone diagram that Doctors Kelly and Victor completed for the problem of caring cards not being sent. They used the classic categories of people, methods, materials, equipment, and environment here, and filled in the barriers that caused caring contacts not to be sent to patients. Dr. Kelly noticed that there can be subcategories within this diagram. She saw that under the equipment area, there are 3 different problems detailed under the printer section of the diagram, and 2 different issues under the mail in the materials section. Now that the doctors identified the causes leading to the effect, they need to develop a way to influence those causes. Since there are many causes leading to the effect of carrying cards not being sent, it's helpful to tackle them one at a time. They decided to go after the low-hanging fruit, so to speak, and look for problems that are more easily solved. So to start, they designed a process around medical assistants going to the mail processing center with completed carrying cards after the clinic closes. They enlisted two medical assistants, Dora and Kevin, for this task. Then they decided to address the issue of providers having no time to add additional administrative tasks, realizing that this could severely impact their ability to complete carrying cards. They also realized that while they had engaged the other providers to send carrying cards to patients, they did not include other people in the clinic. So they decided to send carrying cards themselves for a 2-week period and complete a PDSA for this activity. In addition to Dora and Kevin, they enlisted Maria, the nurse manager, to track and compile the data for this project. The customer service representatives already handed out the PHQ-9s at check-in, so that part of the process was already happening. Before we explore the PDSA that the clinic members completed, I wanted to point out one more thing about the fishbone diagram, and that is that you can take one issue from your diagram and break it down further into another fishbone diagram to find its causes. In this example, we're using printer bottlenecks as the outcome that we're looking to change through use of the fishbone. We use this specifically because it's an example that's been shared with us by participants, and it may be something that happens in your clinic. But remember, the fishbone diagram can be used for any clinic procedure that you want to improve. In this example, the printer has many demands on it, and it may take several key people in the clinic to solve all the problems that it presents. Identifying all the bottlenecks like this can sometimes lead to a complete change in processes, like sending carrying cards through the EMR instead of trying to mail them. The important takeaway here is that during your participation, in my mind, you're likely introducing new processes into your clinic. While doing so, it's important to evaluate the effectiveness of these processes and identify any barriers to implementation. Tools like the fishbone diagram and PDSA can help you during your evaluation. It's also important not to overcomplicate the use of these tools. One of our content experts shared that at her clinic, she keeps a blank fishbone diagram hanging in the staff kitchen. Staff can identify a problem that they'd like to fix and list it as the effect on the fishbone. Then other staff can add to the fishbone over the upcoming days and weeks while they're in the kitchen. This way, leaders can then take the fishbone back to a meeting and see input from many different staff members on what causes they feel are impacting a problem in the clinic. Teaching your teams about these quality improvement tools and making them accessible to all staff can be helpful when working on improving any processes in your clinic, and especially when working to improve suicide prevention processes. Now that you have had an introduction to the fishbone diagram, let's look at family clinic again and see how they do with their PDSA. Let's take our caring contacts example a step further by applying the techniques and frameworks we just discussed. Starting with the model for improvement, we'll walk through how its 3 guiding questions can be used with the members of Family Clinic. The model for improvement contains 3 questions and a PDSA cycle. This setup helps us see how the questions, what are we trying to accomplish, how will we know that a change is an improvement, and what change can we make that will result in improvement, can guide planning and set the stage for a successful PDSA cycle. The 3 questions can be asked in any order, although the order seen on the slide is the most commonly used. When doctors Victor and Kelly asked the first question, what are we trying to accomplish? They remembered not to aim for 100% improvement. They wanted to leave themselves some room for error since they were starting a new process. They decided that they would aim to reach 75% compliance with sending the cards. That would give them room to improve, set a realistic goal, and account for any bottlenecks or obstacles that they encountered during the process change activity. Going through these questions is an iterative process so they would return to earlier questions as ideas formed on what process they want to change and how they want to change it. Once they answered these three important questions, it's time for the PDSA cycle. When you're working on your PDSA projects, asking these three questions can help you focus and inform your decisions and process as you work through the plan, do, study, and act sections of the PDSA cycle. On this slide, you'll see how the clinic team brainstormed and identified the problem that they wanted to solve using information from their clinic to inform the process. I'll give you a second to look at the clinic's answers. When it comes time to complete your own PDSA, you can use these three questions to brainstorm. While we won't be evaluating those sections, we would like to see your thought processes and brainstorming your activity and encourage you to use them. Once they work through the three key questions in the model for improvement, what they were trying to accomplish, how they'll measure success, and what changes that might lead to improvement, they were ready to move into the PDSA cycle itself. These questions helped shape their plan and guide their actions as they test and refine their ideas. To make your goals even more actionable, it's helpful to use the SMART framework. Setting SMART goals gives your PDSA a clear direction and makes it easier to track progress. Let's take a quick look at SMART goals, what SMART goals are, and how they can be applied using caring contacts as an example. Specific, Doctors Kelly and Victor will send their patients who score 1 or more on question 9 of the PHQ-9 a caring card and include a copy in the chart. Measurable, Maria, the nurse manager, will review the doctor's charts of patients seen between September 1st and September 14th, 2025 for the number of caring cards sent. Attainable, Doctors Victor and Kelly will send caring cards to 75% of these patients during this period. Relevant, sending caring cards to a patient is part of the zero suicide care pathway. And time-bound, caring cards will be sent between September 1st and September 14th, 2025. SMART goals are important because they help frame and define what you want to accomplish. Without SMART goals, it gets harder to guide your PDSA and gather data on what you're doing because you haven't defined what you want to do. Some of you may work in small clinics or be a one-person show, but when you're completing a PDSA, it helps to involve team members and leaders whenever you can. Ideally, you would want to involve a system leader like a MyMind PO lead who can give you support with ideas and aspects related to implementing your PDSA. Then you would need to define who your stakeholders are depending on your project. You would want to involve someone who is familiar with the process being improved, someone with quality improvement experience, and someone who is a day-to-day leader or manager. You could also enlist a patient or two to get their perspective as well, since your project most likely affects them. In the example of family clinic, the customer service representatives hand out the PHQ-9. Doctors Victor and Kelly send caring cards to anyone who has scored more than 0 on question 9. The medical assistants take the cards to the mail processing center, and the nurse manager, Maria, compiles the data. Once your team has finished brainstorming and identified the problem that you want to address, you're ready to move into the PDSA framework. The first step is plan. This is where you define your problem, understand the current condition, and set your goal, ideally using a SMART goal. Let's walk through what that looks like in practice. For plan, Dr. Kelly wrote out what they planned to do for this PDSA. She remembered to use a SMART goal here and defined the patient population that they were planning to reach out to with their caring cards. When you're working on your PDSAs, remember to think small. The PDSA is all about testing a small change in a process. For example, if you want to incorporate caring cards into your clinic processes, set a goal of something like the example here. This is a new process, so don't expect to do it perfectly. Also, you will often go through several iterations of PDSAs as you implement a new process in your clinic. In this example, Doctors Victor and Kelly are taking part in the cycle, and the plan is to send caring cards to 75% of patients who scored 1 or more on question 9. One other important thing to remember here is to ensure that everyone involved knows their specific roles. Here, the providers, customer service staff members, medical assistants, and the nurse manager all know what they will be doing in carrying out this plan. For DO, they piloted their plan. The nurse manager collected the data as they carried out the plan. But with your PDSAs, remember to get feedback from the staff members carrying out the plan. Getting feedback is important as those involved in carrying out the plan can give you information on what is working and what isn't. Remember to track your specific results. In the case of this PDSA, 135 of patients who saw Doctors Victor and Kelly were screened with a PHQ-9. 4 of these patients scored 1 or more on question 9. These 4 patients were sent caring cards. When you're planning your PDSA, you'll want to think about how you'll track this information. It will probably be easy to pull if you have an EMR, but if you're tracking it on paper, you will need to do some planning. Either way, make sure everyone knows how and where to track the data. And it helps if you track the data as you go. This will prevent your needing to gather a large amount of information at the end of the cycle. Also, when you're planning your PDSAs, think about what your numerator and your denominator are. In this case, one denominator that you can consider is the total number of patients screened with a PHQ-9, and the numerator would be the number of patients who scored 1 or more on item 9. In the case of this PDSA, there is another numerator and denominator that we need to consider, which is how many patients are getting the caring cards during the PDSA cycle. If the denominator is patients scoring 1 or more on item 9 of the PHQ-9, think about what the numerator would be. In this case, the numerator would be patients who were sent caring cards. For study, the doctors analyzed the data that Maria had compiled and discussed the project with the team. One patient called them and let them know how much he appreciated getting the caring card. Dora and Kevin, the medical assistants, said they struggled on the days that they had to go to the mail center at the end of the day with all of their other responsibilities. The team decided that they would do another PDSA cycle and send the cards on Wednesdays, since the clinic was only open for patient care for a half day in the morning. When you look at your PDSAs, determine what your results are. Did you get the results that you expected? Were there unforeseen issues with the change in processes? Do you need to make further changes? Remember that the first PDSA cycle may not work. That is okay. You're learning what works and what needs to be changed. Since they decided to do a second PDSA, the team chose, we're going to revise this test and repeat another cycle for their ACT. When you're in this stage of the PDSA, what are your next steps? Will you adopt the change? Will you revise the test and make some tweaks in the process? Or will you abandon this cycle altogether and start over with something different? Remember that you might go through several PDSA cycles. Your original idea may need tweaking as it might reveal issues in the process that need to be worked through, like the provider's appointments getting backed up or patients experiencing a bottleneck at the customer service representative station. For this training, we took a deep dive into lethal means counseling with case studies and took a look at the family clinic and how they worked through a fishbone diagram and a PDSA to incorporate caring cards into their clinic processes. Remember that discussing case studies with your teammates can support practice staff in feeling more confident in their suicide prevention strategies. Caring cards are an evidence-based method of suicide prevention. A fishbone diagram can help a team work through challenges, especially those with multiple causes, and PDSAs using SMART goals can help illuminate barriers to processes, opportunities for growth, and whether a change in a clinic process is successful. For next steps, we'll be asking you to complete the care pathway survey again so that we can understand the suicide prevention strategies used at your practice and be able to track this information across the collaborative as the MyMind CQI grows. If you're covering more than one practice, you'll need to complete a survey for each practice that you cover. Sign up for Module 2, Strengthening Care Pathways, if you haven't already. You can always log in and complete these right after the training while it's fresh in your mind. And remember that if you really want to plan ahead, you can sign up for all the trainings at once. Also, there is an appendix on the slide deck with information on barriers, successes, and opportunities that I gathered from your first PDSAs. Check it out and see if you can apply any of this information to your clinics. There is a QR code and the contact information for the 988 call-in text line. As a reminder, there are some very cool provider and patient-facing tools to use on the MyMind Partner Portal, so log in there to check those out. And remember that you can use these resources too if you're struggling. When we're caring for others, it's easy to forget that we can be struggling ourselves. So remember to check in with yourself and access the resources for yourself if you need them. And if you would like to get a jump on the PDSA that you need to complete this year, feel free to complete it. The portal is open. But if you want to wait, there is time. It isn't due until May 1st, 2026. Here are our references. Here are the references specifically for the effectiveness of caring cards. As a reminder, you can always reach us at the above contact. And if you have any questions, feel free to email me at this address. Thank you again for your participation in the MyMind Year 2 series of trainings.